Hi, my name is Dr. Megan Winter. I work at Winthrop University Hospital in the Division of Surgical Oncology. One of my prime areas of interest is in soft tissue sarcomas and in cancers that arise from the skin, such as squamous cell carcinoma, basal cell carcinoma, melanoma, and Merkel cell carcinoma. Soft tissue sarcomas are a cancer that arises from the connective tissue that makes up our bodies, in contrast to some of the more common cancers that we know of in the United States: breast cancer, prostate cancer, colon cancer. These are cancers of the glands, whereas soft tissue sarcoma comes from the muscle, the fibers, the tissue that helps hold all of our organs together. They are not only incredibly rare, but they come in dozens of different subtypes depending on what kind of tissue gave rise to the cancer. They are therefore sometimes very hard to diagnose and very hard to pin down in terms of their subtype, which matters a great deal for me as a surgeon because I may treat one type a little different than another. Soft tissue sarcomas can come in a limb, in an arm, or in a leg. They can come on the back, or they can come actually inside the abdomen, in what we usually call the retroperitoneum. In my practice, I treat all kinds of sarcomas, and I rely on a number of different people to help me treat these tumors based on where they are. For instance, my radiologists are one of the most important people when I'm first meeting a patient and trying to understand not only what kind of tumor this is, but does it need a biopsy before we move to surgery, and what my surgery will be like, where I'll be operating around. Will I be around nerves or arteries or veins that are important? My pathologists are key because they have to help me differentiate between the dozens of different types of soft tissue sarcomas that can arise in the body, and they help me understand how to talk to a patient about what kind of treatment is required. Around the time of surgery, I rely on some very important ancillary services. If a soft tissue sarcoma is in a limb, I have to rely on some of my neurosurgical colleagues to help monitor some of the nerves in that limb as I operate. I rely very heavily on my physical therapists and occupational therapists to help patients get back to full function after a procedure that I've done in the arm or in the leg. And I rely on my radiation oncologists a great deal as well, because there are some sarcomas that have the potential for coming back and who we can reduce the risk of that recurrence by including radiation therapy along with our surgical therapy as treatment. Surgical principles I think about in soft tissue sarcoma are often a little at odds with the trend that's going on in other areas of surgery. For instance, there is a wonderful explosion of the applications of minimally invasive surgery. For a sarcoma in the abdomen, for instance, however, my best chance at reducing the risk that that sarcoma is going to come back is to remove the tumor in its entirety with a rim of normal, healthy tissue around it. This often requires an open procedure, and it often requires the collaboration with a number of other surgeons based on where the location of that tumor is. For instance, I can treat a tumor in the retroperitoneum where I have to have a vascular surgeon available to me, a urologic oncologist available to me, even a neurosurgeon available if the tumor is around some of the major nerves that go to the leg. All of those individuals help me review the images ahead of time. They're ready for their particular part in the operation, be it moving an artery or a vein or protecting a nerve in the course of the dissection, all in the service of making sure that the operation that we do for this sarcoma is the best operation at the very first, and really minimizes the chances that we'll ever hear from that tumor again. Likewise, when I operate on a sarcoma on a limb, my first priority is making sure that the major functions of the arm or the leg are protected and preserved. If I need a vascular surgeon there, to help me dissect a tumor away from the major femoral vasculature going to the rest of the limb, I'll have her there. If I need a neurosurgeon in the room to help protect the femoral nerve or the sciatic nerve, they're there with me. Because again, my aim is to make sure that I do the best cancer surgery I can do while preserving as perfectly as I can the function of the limb. Once a patient has a diagnosis of sarcoma, nearly everyone will have some form of chest imaging, usually a chest CT, to rule out metastatic disease. And very naturally, every patient who has a soft tissue sarcoma diagnosis is worried that it may someday come back. The risk of recurrence varies based on the type of tumor that we diagnose, the size, and what it looks like under the microscope. But every single patient with sarcoma will be followed. And that may include, for sarcomas of the limbs, an ultrasound or an MRI of the limb on a 6-month or annual basis. It will for sure include a clinical exam by myself and by their primary care physician. And it may include chest imaging on an annual basis. Once we establish a diagnosis and once we complete the treatment for a sarcoma, every patient gets a post-treatment surveillance plan that will include our plan for the frequency and duration with which we'll get imaging, the number of times and how frequently they'll need to see me for the first couple years, and then we'll spread it out a little thereafter. But that person will be followed for the rest of their life to make sure that the sarcoma doesn't come back.